Donc, on va commencer sur cette tombe 1 sur l'épidémiologie.
So we'll start with the epidemiology of dual
Nous aurons
diseases.
donner la parole à Bruno Falissard.
I'll give the floor to Bruno Falissard,
de cette plénière. Merci.
who will be monitoring
Merci de nous faire l'amitié de
this session. Thank you very much for coming.
cette session.
Thank you very much. So this is my pleasure to introduce this session about epidemiology of drug use and abuse. And so the first speaker will be Professor Jürgen Hrem. He is Executive Director of the Institute for Mental Health Policy Research at the Campbell Family Mental Health Research Institute in Toronto, Canada. He is Professor and Chair of the Addiction Policy at the Dalla Lana School of Public Health, also at the University of Toronto. His research are about population health and regulatory policies in the area of substance use and abuse. He has many awards, many international awards, and he works regularly for the WHO. We are eager to listen to you, Jürgen. You are much welcome.
Merci beaucoup et merci pour venir.
Thank you for coming.
Je n'avais pas parlé
I'm not going to continue in French because I couldn't do it. My French
mais je peux
is inadequate for that. However, I'll be able to answer some of your questions in French.
try to walk you through alcohol and depression and what do we know about their reciprocal condition. So basically, what I'm trying to say here is that I will try to solve some of the mystery about causation here, but I will leave, of course, with new questions. So, the very simple thing, a thing which all of you know, is that there's a strong association between heavy alcohol consumption or alcohol use disorders and depression. That is known by anybody who is doing clinical research, who is doing population-wide planning. Alcohol, as many other addictions, as well as depression and many other mental health conditions, are associated. And usually, there's about a twofold risk above of what you would expect in general population samples. I just put there a recent meta-analysis which has been published about 2 months ago in addiction. It's a wider category than just depression, mood disorders, but this wider category is very much dominated by depression. That's the largest category within that. Some other results from huge studies, Cran et al., Bridget had done an analysis of a US representative sample of more than 50,000 people, and the odds ratio for major depression among people with any alcohol use disorder was about 2.3, and the odds ratio among people with major depression, the odds ratio of alcohol use disorders was about 2.1. Then a lot of studies show associations, show pretty much what we expect. I'll just mention two. A combined analysis of the World Mental Health Survey of the year 2020 showed that no matter if you go over the lifetime, if you had an alcohol use disorder, you had about a 15, if you had a depression, you had about a 15 to 16-fold chance of getting alcohol use disorders later in your life. And if you had an alcohol use disorder, you had about a 12 times. We are talking about 12 times higher chance to get it. Then in the latest meta-analysis for the comorbidity, which has just been published, you had a lifetime risk of concurrent AUD and depression of 2.3, adjusted a little bit higher, and a period, meaning within the same period when there was the study, you had also risks between 2 and 2.7. So in total, we have this huge association. Now, what does that mean? What does it mean for causality? Does it mean that one is impact on the other is impacting on the one, or is there another reason? So in the literature, you basically have three theories. First is that depressive disorders increase the risk of heavy drinking, alcohol use disorders, and this has usually been explained by what is called the self-medication hypothesis, meaning that people start drinking or start drinking more because of depression, because they feel that alcohol is actually relieving their depressive symptoms. And in order to get this relief, people drink more, and some of them end up with alcohol use disorders. This is a very plausible hypothesis. There are a number of studies who have shown that this is actually happening. The second is that heavy drinking and alcohol use disorders increase the risk of depressive disorders. And that can be done via changes in metabolism. There are studies on the neurotransmitter functions, or as a consequence of alcohol-related problems on social life. There's a number of studies which show that alcohol use disorders may be linked to going down on the social ladder, and that in turn causes unemployment, causes problems with the family, etc., which can trigger depression. So that's the second hypothesis. And then both conditions could be overlapping in their genetic vulnerability and or have common risk factors. Those two hypotheses would basically state that the dual disorder of alcohol use disorders and depressive disorders are not because one is causing the other, but because there are third reasons which impact on both of them. So, these three mechanisms have been shown or postulated by different studies and by different scholars. I will just go through the third hypothesis, that there's no causation first, because both epidemiological studies and genetic studies have shown to the contrary. That means basically all of the analysis we have done could not find risk factors which would explain the association between alcohol use disorders and depressive disorders sufficiently, meaning that they would not explain sufficient variation to say, okay, probably it can be explained by risk factors A, B, C, D, E. No, this was not the case, and all attempts empirically to show this epidemiology have failed. In terms of shared genetic susceptibility, there is more or less consensus, maybe one or two exceptions, that AUD and depressive disorders arise from two distinct genetic factors, And I'm just citing the classic Kendler and a more modern study from Grotzinger et al. So if we cannot explain the association of the two by a third factor, we are left with the question, which one is more important, and does one more cause the other, or the other more cause the one? I'm not trying to come up with an explanation that all of depression is alcohol-related, or all of this interaction, this is not the case. Very clearly, some association is simple by chance, because both depression and alcohol use disorders are one of the most prevalent conditions in our society. I'm trying to explain the additional, more than you would expect by pure chance, and some of that could be explained by a causal pathway from one of the conditions to another. So, there's another complication I would just like to mention. In the ICD or in the DSM, whatever you use, there is the diagnosis of alcohol-induced depression, meaning this is part of a larger category which says substance or medication-induced depression. This concept also exists in the ICD-10. It's a long-known concept, and basically it is defined as there. I will not read all of the details, but the basic gist of it is, we know that substances may induce depression, and in this case, depression will cede as soon as substance use is also discontinued. And these criteria are relatively vague. And because they're relatively vague, the key there is, well, there is a correlation, there's a comorbidity, but we have no other explanation that the depressive disorder is not substance-induced. That's very vague. You know, it's people usually do not even take a systematic investigation of that in their busy clinical schedules. So the basic gist is that this will make up less than 5% of all of the depressions, and it is an underused category. We don't know if it's correctly underused or not, but it is existing. So there is at least some depressions which by classification would be caused by alcohol use disorders. Now for the main others. Well, I've already talked about this alcohol-induced depression, and I will now go to the other considerations. So let me start with a landmark study of 2009. Why is it a landmark study? It was a very long longitudinal study. It has more than 1,000 people. It has almost no dropouts, a very, very low of dropouts. And people were basically studied from their adolescence 25 years on. Meaning a lot of them, a lot of those young kids have actually developed both alcohol use disorders and depressive disorders. And this is a statistically quite sophisticated analysis, which is using 3 time points, ages 17, 18, ages 20, 21, and ages 24, 25. In their methodology, MD stands for major depression, and AD stands for alcohol abuse and dependence. And I'm saying that because I kept their terminology because I have some of their slides, and it makes no sense to redraw all of those slides with my terminology. So this is the interesting study. What they were estimating is at 3 time points. The first time point is at the bottom, the last time point is above. They were estimating the reciprocal relationships, meaning with some statistical constraints, you can ask whether there is, of course, a time lag in the relationship, or there is a reciprocal relationship. And what they found is basically that of the effects, the effect from alcohol use disorders on depression was significant and okay, whereas the effect from the major depression on alcohol use disorders was not significant. The model overall was an okay model. The mean error was good, and the goodness of fit was quite high. If they were only modeling a unidirectional effect from alcohol on depression, it was again highly significant, and it showed quite good goodness of fit statistics. Whereas if they modeled the effect from major depression and alcohol use disorders, it was positive, it was significant, but a much lower effect size. Meaning, from this analysis, it was pretty clear that the majority of the additional comorbidity was probably caused by alcohol use, heavy alcohol use, or alcohol use disorders. And since this is a model which also has some indigeneity, which has some of the more control than the usual statistics which you see, this was a landmark study. The conclusion of the authors, the conclusion of the authors disappeared, but I can tell you, basically, Ferguson et al. Concluded that alcohol use disorders should be seen as a major risk factor for depression, which is leading to their conclusion that more than 50% of the additional co-occurrence of alcohol and depression was actually caused by alcohol use disorders. And in another article 2 years later, where they screened the whole literature, they reiterated that with common pathways. I show you one more study, which is not yet published. It is by Aurélie Lasserre and a group in Toronto. Basically, it looked into relatively old data, again, a general population survey where 43,000 participants were in wave 1 and 43 in wave 1 and 35 in wave 2, and again a longitudinal study. And because of this is such a big study, large study, relatively good dropout rates, of course much higher than in the smaller study where basically all of the participants were part of the team after a while. This is a general population study in the US, and we were trying to do that to try to explain the so-called deaths of despair. I will come to that later, but here I want just show you the different characteristics. And this is how alcohol use disorders can predict depression. And you basically have the lifetime abstainer as the reference category. And you see if you go into drinker without AUD, and then remitted AUD, and then mild AUD, moderate AUD, and severe AUD, as defined in DSM, you would see that the more severe your alcohol problem, the higher the relative risk to be depressive. And that is a clear dose-response relationship. So not only are most of those odds ratios significant, but also the trend is significant, meaning they separate from each other. I want to also mention that alcohol consumption by itself, meaning people who drink alcohol but who are not alcohol dependent or who are not having any alcohol use disorders, also have a high risk of depression if they drink a lot, meaning more than 100 grams for a man per day, and 100 grams is about 1.5 bottle of wine, depending how much alcohol the wine has. And for women, it was about 60 grams, which are 5 glasses of wine. So, what about depression? Depression did not predict alcohol use disorders 2 years later. So basically, again, a finding that the effect from alcohol to depression was much stronger than the effect from depression to alcohol, which is there, but not significant. So, what was the conclusion? Well, the risk of developing an incident depressive disorders did increase gradually with the severity of alcohol use disorder at wave 1. And of course, we excluded everybody who had a depressive disorder before, etc. So this was quite correct. It was an incident new depressive disorder. In that low socioeconomic status, the poor was an independent risk factor for AUD and for depressive disorders, but it did not modify the association between the two. DD, depressive disorders, were not significantly related for incident AUD. And the limitation is pretty clear that we did, even though at 40,000, you've seen the numbers of depressives, you've seen the numbers with alcohol use disorders, and the number with both. We are running out of sample to properly model SES in a triple interaction. And the conclusions were more or less that the results were more consistent, again with a pathway from alcohol use disorders to depression than with another pathway the other way around. So, these were 2 main studies which were pretty well controlled. This is a meta-analysis. It's a meta-analysis from last year. It is medium quality. There's quite a lot of problems with the meta-analysis, but basically it found the same result based on 42 studies. The relative risk of AUD for developing subsequent depressive symptoms had a relative risk of about 1.6, which was significant. So it is not only those 2 well-controlled studies, which I wanted to highlight, but it has also the overall literature. But as I said before, this literature has 2 problems. A, the quality of each individual study in those 42 is not that great. and B, the method of analysis, inclusion-exclusion of those meta-analysis is also a little bit questionable, but I'm sure if we would have done a different meta-analysis, somewhat similar results in the relation between AUD and depression would appear. The more, the better the study, the more controlled, the higher the pathway from alcohol use or alcohol use disorders on depression. So, what is the conclusion on causality? First, while both directions of causality could be found, the impact of heavy drinking AUD on depression seems to be stronger than the opposite direction. This finding, as I showed you, was confirmed by several very good controlled studies, and these were still studies without experimental control. We cannot manipulate depression or alcohol use disorders and induce them to people very clearly. So there are always doubts. The best statistical methodology may fail, but still, this is a pretty good conclusion. Secondly, in addition to causing depression, alcohol use disorders have been shown to actually worsen the cause of depressive disorders, and this has been shown in 3 meta-reviews, and one of those reviews was suggesting a dose-response relationship. So, what would be the conclusions for treatment? If we have concurrent disorders, if we believe that one may be more the cause of another, we may have some conclusions for treatment. The NICE guidelines, which are probably the most cited guidelines internationally, from the respective center in the UK, gives the following treatment guideline. For people who misuse alcohol and who have comorbid depression or anxiety disorders, treat alcohol misuse first. This is a direct citation. Yet another word, alcohol misuse, whatever that means. As this may lead to significant improvement in the depression or anxiety. If depression and anxiety continues after 3 to 4 weeks, then assess it and send people to a specialist. Or if you consider yourself a specialist in treating depression as well, you should use the respective NICE guideline. What is the basis for that? Well, I'm trying to summarize basically about 30 pages, but the basis of it is that it has been shown that in the co-occurring alcohol and depressive disorders, a lot of the depressive disorders actually disappear after 3 to 4 weeks. And this is independent whether it was a substance-induced depression or a so-called independent depression. And there's another thing I would like to talk to you about, that the effect of antidepressant therapy seems to be lower in those comorbid patients than in patients who have depression and no substance use disorder. This is true not only for alcohol, this is also true for other substances. So, but the treatment reality is different. When I looked for trials which was exactly supporting that as a controlled clinical trial, there was none. And the last overview, the last meta-analysis, again from 2021, did not find any trial where this treatment recommendation as a recommendation was tested in an RCT. It was derived from more than 20 or 30 studies, but none of those studies had exactly that kind of a treatment scheme against another scheme, let's say treatment as usual. So this is part of the problem. Now, the problem with the SSRIs is also a quite interesting and problematic thing, because in many countries, and I can tell you from our country, Canada, where SSRIs are used quite a lot in alcohol use disorder treatment, even without concurrent depression, the Cochrane review did not find a lot of effectiveness of SSRIs in the treatment of comorbid persons. And I'm just giving you a number of examples. Depression severity, no significant difference. Full remission of depression, no difference. Alcohol abstinence day, no difference. Consumption per drinking day, there is a significant downward trend, but this is only 1 out of 25 outcomes tested, and actually they should have corrected for that many tests in the same sample. So we would expect at least 3 significant outcomes anyway. So to have 1 is not that convincing. Heavy drinking days per week, no significance. Time to relapse, no significance. And these results have been corroborated by new trials where some of that even found a worsening of alcohol conditions with treatment of SSRIs. A new network analysis basically found a small effect of SSRIs on functional status, no reliable effects on alcohol use, and a higher risk of adverse events, sort of confirming the 2018 with a different methodology. So, where does that leave us? Basically, it leaves us with the question that we have to do more. I'm not that much convinced about a guideline which is basing most of its guidance on evidence which is not RCTs. So we have to come up with RCTs which would actually test SSRIs as one of the adjunct therapies, which would test the sequential treatment, clearly look at all of the diagnosis in the beginning, but treat depression only after 3 to 4 weeks, and look at the success of that. So we need to have more evidence. In the meantime, should we firmly advise more strongly against treating depression from the start, which would be against some of the recommendations, especially which were derived from parallel versus single treatment, but again, no sequential treatment. So parallel treatment of both conditions is better than treating only one, but we don't know if it's better on treating them sequentially. That is something we really have to find out. 2 more research things I would like to mention. As I've said before, in the US, we had, since 2015, a decrease of life expectancy. And the decrease of life expectancy means that since the year 2015, US men have lost more than 3 years of their life expectancy. The last big drop was, of course, also COVID. But that was way before COVID that they started. And what were the 3 main problems which caused this drop? It was not heart disease, it was not cancer, it was not any of the usual suspects. It was liver cirrhosis, it was suicide, and it was poisoning, meaning overdose deaths and alcohol overdoses. And this is something which, of course, is very much related to both alcohol use disorders and depression. Suicide, everybody thinks about depression. A lot of alcohol people think about alcohol as well. Liver cirrhosis in France, about 70% of the liver cirrhosis are caused by alcohol. Even though not in the literature, there's more about the non-alcoholic liver cirrhosis these days, but in the population, this is what we find. So the question is, how much does the interaction of AOD and depression relate to these depths of despair, and what role does lower socioeconomic status actually play? Because in the US, the rich had an increase in their life expectancy of about 1.5 to 2 years. And the poor were way, way more down. So this is what it has happened. And this problem in life expectancy has been a problem by the lower middle class and the lower class. So this is something I would like to note as an open research question. And finally, if this is the case, we should start modeling, population modeling, the burden of disease study, with including the effect from alcohol use disorders on depression. And we will propose this to the IHME in Seattle, the group there, and to the WHO, because we still have two different burden of disease studies for alcohol, one from the Global Burden of Disease unit and one from WHO. I'll stop here, and of course, I'm happy to receive any questions. Thank you.
And effective talk. Are there any questions? I will perhaps begin with during the lockdown that we experienced these years, everybody did epidemiological studies with alcohol consumption, depression, and in my country, we found a G curve. And so with a small level of alcohol consumption was negatively correlated with depression. A high level of consumption was, of course, related to depression, but not a small. And so we were very embarrassed to communicate these results, to communicate to the journalist or to the general population. And so we had discussion with my colleagues, and they decided not to communicate the G. And I was a little bit embarrassed by that, because I think that our duty as scientists is to say the truth to people and to be honest with them. And so, because you live in a different culture and country, what is your opinion about that?
I mean, your question has three aspects. The first aspect is pretty clear, and I think we have to communicate results, no matter if we like them or don't like them. And we cannot say, oh, this may have negative repercussions or whatever, the media will not understand it or will have the wrong. No, we report the results, we try the best to interpret them, so that's pretty clear, and that's not specific to the countries. Secondly, in France overall, we have a phenomenon during COVID that alcohol actually went down overall, and that has to do with less availability, it has to do with the lockdowns, it has to do with the closure of bars, etc. But we have a polarization. Meaning we have lots of people who didn't drink a lot, and then they reduced even further. And those who were very heavy drinkers, people with alcohol use disorders, in some probably increased their consumption. I don't have the data for France, but we have the data from 3 neighboring countries, all of the same tendencies. So we would it makes a lot of sense to expect that alcohol-induced depressions would go up. The third is the J-shaped curve. A J-shaped curve is always depending on the left-hand side. Is it current no drinkers, or is it lifetime abstainers, and how reliable is that? And this is what causes J-shaped curves or findings that the control group was not exactly checked. And I don't know the study. First thing I would check is, what is the control group? Do we have a reliable group? But then the curve, which would be expected from the biology, is a relatively flat curve which goes up pretty quickly. So it would not be a linear curve. You would expect an accelerated curve just from the biology.
Okay. Thank you. I see a question here.
Si.
Bruno. Merci. Thank you for the quality of your communication. Je vais poser la question en français. Bruno, help me.
I'm going to ask the question in French.
La population qui
Do you think the population that is
d'alcoolisation
in the lower levels of
est-ce que la population qui se situe là ou dans les hauts niveaux de consommation,
alcohol consumption,
le facteur de risque le plus important,
is that where you have the higher risk of going over to suicide? Where do you think is the highest risk for the population? Is it in the high level or in the lower level? Because in the high level, very often they fight against, fight the disease.
Just to be sure that I understood it correctly. You were speaking about the low versus the high level of alcohol consumption in relation to the risk of suicide.
Exactly.
And what we find with this is very clearly, again, a very flat curve, and then it accelerates. But suicide has two causal mechanisms for alcohol. I mean, there's more, but the two are very important. There is alcohol use as a cause for suicide, meaning you're so desperate, you see no more way out than to suicide yourself because of the situation the addiction has, or the heavy use has brought you into. That's one. The second is, it's also related very much to the alcohol consumption before the suicide. These may be people who on average don't drink that much, but they need the alcohol to get the courage to commit suicide, because most people have a tendency not to commit suicide, and even if they think about it, they do not do it. I mean, we have way more suicide thoughts than we have suicide attempts, and more than real suicides. And alcohol and medications are a use for that. So we have these double things. So in the first one, the curve is about like that. And in the second one, overall, people who had committed suicide in a country like France, and I'm taking the statistics from Germany as a similar country, what people had in their blood was more than 3 drinks on average when they committed suicide. Obviously, there were ones who had quite a lot and way more. So this is also playing a role, and that's completely independent on how much they drink normally.
Okay. Thank you very much.
You're welcome.
Thank you very much. Just a last question here. Yes.
Yes, thank you very much. I have just a question for the treatment. Doesn't work? You have spoken about that the serotonin agonist can worsen the situation. Another treatment for the depression can help, or it's also a treatment of antidepressant?
The meta-analysis overall have shown a modest effect of other non-SSRI treatment on alcohol use disorders. These are a number of RCTs which are by now pretty long ago conducted, because there's not a lot of new studies on that. But there seems to be a moderate effect of other than SSRIs on alcohol, which may help. The problem has specifically been found with the SSRIs. And I've mentioned it because by now, this is the most used depressive treatment in comorbid disorders.
Thank you very much, Jürgen. And so now we are going to listen to Professor Matthew Hickman. I think he is okay and online. Can you hear us, Professor Hickman?
Yeah, I can hear you. Can you hear me?
Bye-bye. So, Professor Hickman is professor in public health and epidemiology at Bristol Medical School. He is co-director of the NIHR Health Protection Research Unit in Behavioral Science and Evaluation. He works in the epidemiology and public health consequences of drug use, and we are eager to listen to you, Professor Hickman.
Thank you. Is someone going to do my slides?
This is perfect.
Great. Thank you. I mean, just to say, I was really sorry not to be there. I'd love to have seen Jürgen and you all, and I would love to have got out of this country, but sadly I have to stay. So I will make the slides available in PDF, and very glad to answer any questions at this time or another time. So I'm going to talk about, I've been invited to talk about opioid agonist treatment and prevention of drug-related deaths. And I'm going to also talk about some other harms that OAT can prevent. Now, I think it's being translated. If I go too fast, just tell me if that's okay. So I'm Matt Hickman from Bristol, and here are some of my collaborators. Can we go to the next slide, please? Okay, so a little summary, just in case we run out of time. So I'm going to show you from systematic reviews that there is strong, consistent evidence that opioid agonist treatment can reduce HIV and hepatitis C transmission. It also improves HIV and hepatitis C treatment outcomes, which I will not show you. It halves mortality risk. The risk of overdose, drug-related deaths, and suicide are substantially reduced. We'll show weak evidence that other causes of death are also lower: liver disease, cancer, cerebrovascular disease. In the review level evidence, there's virtually no evidence from RCTs on mortality. We've got emerging evidence that needs to be strengthened, that OAT in prison can reduce the mortality risk for people with opioid use disorders leaving prison. But mortality risk is elevated in the first 4 weeks leaving opioid agonist treatment, when there is relapse and people are not tolerant to opioids. And also there is an elevated risk of death in the first 4 weeks on methadone, but not buprenorphine. I'll summarize some model evidence which show that the population benefits of scaling up opioid agonist treatment or improving retention can be considerable. And end, I think, with that we should start evaluating opioid agonist treatment delivery and impact on population health in France and in other countries in the EU as well. Next slide, please.
Next slide.
Next slide. Is that okay? Oh, thank you. So this is a little old, but shows a meta-analysis of studies looking at the impact of opioid agonist treatment in relation to HIV transmission. And it's a forest plot. So each line is an individual study, and then the diamonds showed for all pooled studies, and also studies were affected at the give you the weighted estimate across all of the evidence. And if it's to the left, it favors opioid agonist treatment, reducing HIV transmission, and to the right, suggests that OAT leads to an increase in the outcome. And here we see that from across studies globally, that there is strong evidence that opioid agonist treatment reduces HIV transmission by about 40%. Next slide. Thank you. And this shows a meta-analysis on hepatitis. Oh, back one, please. That's it, thank you. So this shows a meta-analysis for hepatitis C transmission for adjusted studies that had enough information to adjust the intervention effect, and it shows it for Australia, North America, and Europe. And there were about 12 studies with over 6,000 participants and 1,000 hepatitis C cases. And it shows strong, consistent evidence that being on opioid agonist treatment reduces hepatitis C by about 50%, little heterogeneity. Now, in the world of Cochrane, which we can argue, if I was there, we could argue about, but because these are observational studies, not trials, it's viewed as low quality evidence, but actually it's strong, good, low quality evidence that opioid agonist treatment reduces hepatitis C transmission. Next slide, please. And this is just to show from some models of the combination of hepatitis C treatment and opioid agonist treatment in 3 different scenarios. The first panel, there's 20% chronic hepatitis C among people who inject drugs. In the middle panel, it's 40% chronic hepatitis C. And in the right panel, it's 60% chronic hepatitis C. So what the model shows is how much treatment do you need to reduce chronic hepatitis C to less than 10% among people who inject drugs. In other words, or the incidence rather, to reduce incidence by 90%. So make it a sort of, reduce it as a public health burden. And what you see is that for each scenario, as you scale up opioid agonist treatment and high coverage needle and syringe programs, and they act synergistically, the number of hepatitis C treatments you need in the population to achieve public health elimination is reduced, because what opioid agonist treatment does is it minimize reinfection and transmission in the population. Next slide, please. Okay, so I'm going to go to looking at mortality now. And this was from a previous systematic review, really just looking at what's the mortality rate among people with opioid use disorders or largely heroin injectors, and what's the difference between the population, the mortality rate among people who inject drugs and the general population. And what I don't expect, and this is a massive forest plot and shows massive heterogeneity, which I think is quite interesting. So and there are differences in mortality risk at different time periods, but also geographically. So the mortality rates among these observational studies varied from 0.3 to 9 per 100 person years, 0.3% to 9% per year. overall, the mortality rate was around 1.7 per 100 person years, which is about what it is like in Europe at the moment. And in general, about 10 times higher than the general population. Next slide, please. Now, people inject drugs, people with opioid use disorders don't just die from drug-related deaths, from poisonings. This is from the same systematic review, which is, I forgot to say, was across about 124 studies. And here we can see that, so this breaks it up into the main causes of death. So about a third are from drug-related deaths, from drug-related poisonings, but there's also substantial risk for suicide, as Jürgen has just been talking about, which is the suicide rate in people with opioid use disorders is about 8 times higher than the general population, and is nearly 10% of the causes of death in this population. And then the other key causes are non-communicable disease, about 25%, and then infectious disease, again, another 25%. So what we were interested in doing was updating a review looking at what's the impact of opioid agonist treatment on all-cause mortality, drug-related deaths, but also other causes of death. Next slide, please. So this shows a Prisma flow diagram of a recent systematic review, which was published in JAMA Psychiatry. And so we followed Prisma guidelines and other guidelines for conducting systematic reviews. We wanted to mix observational studies and randomized controlled trials, all of which had to, the PICO was that the patients were people with opioid use disorder, the intervention, opioid agonist treatment, the control were periods when people were not on opioid agonist treatment, and the outcome was mortality risk, whether that's all-cause, overdose, or other causes of death. And what to be included, there had to be evidence of the outcome, obviously, but also that we could look at the exposure, whether or not people were on opioid agonist treatment or not, and then compare mortality rates between them. And going across, I mean, there was about nearly 9,000 studies, but once you sort of get rid of duplicates, get rid of some of the screen for the titles, it fell to about 72 publications, 22 potential randomized control trials, and 36 observational cohort studies. So if we compare that to the previous review, which I think was in the BMJ, that's about twice as many cohorts as the previous review, 6 times as many patients, and 3 times as many person years follow-up. So definitely worth updating. Next slide, please. Thank you. So this is the first forest plot from this new review, and this shows the evidence from randomized controlled trials, which looked at whether or not people were randomized to opioid agonist treatment, largely methadone, but sometimes buprenorphine, and then we wanted to see whether the mortality risk was varied between when people were on or off, or randomized to OAT or not. I mean, there were about 15 eligible randomized controlled trials, mostly in North America, mostly in single clinics, mostly commenced prior to 2010. There were only 40 deaths reported. Only 7 of the 15 controlled trials reported no deaths. And if we look at the diamond, it shows very weak evidence that the mortality is lower on those allocated to opioid agonist treatment. And really, the bottom line is it's completely underpowered. And there were only 3,800 participants. And really, none of the RCTs actually had survival as the main outcome, as the primary outcome. And most of them, when you read them, actually mortality was an adverse event. Next slide, please. Okay, so here's the summary of the observational studies, looking at, this time, at all-cause mortality. So here there were 36 cohort studies, there were 750,000 participants, nearly 2 million person-years observation, and over 20,000 deaths across all of the studies. And in this forest plot, we've sort of aggregated them by geography. So in the first panel is Australia, the second panel East Asia, the third panel is Europe, and the bottom panel North America, and then there's the overall diamond synthesizing the evidence across all of those studies. And what it confirms and shows is strong evidence of a protective effect of opioid agonist treatment globally. The pooled all-cause mortality rate on opioid agonist treatment in those studies was about 1 per 100 person years, 1%, versus 2.4 per 100 person years out of treatment. And the pooled risk ratio was just under 50%, 0.47. We also looked at meta-regressions, and they showed no evidence of a differential effect. I mean, you can see this by geography, but also by study year, sample size, follow-up, age, gender, or comorbidity. And the cohort studies range from about 110 to over 300,000 participants. Next slide, please. So this is confirming the meta-regression, showing that there was a lower risk of mortality when people were on opioid agonist treatment for both men and women, for younger people and older people, for people who injected drugs or didn't report injecting drugs at the time, people who were also diagnosed with HIV or hepatitis C, and also by different treatment provider, whether it was in primary care, in the community, or in a specialist service. Next slide, please. So here we've stratified the evidence by modality of opioid agonist treatment. So there were 22 studies that looked at methadone, which is the bottom panel, and 8 studies that looked at buprenorphine, which is the top panel. And here it's just looking at whether or not there's evidence that being on buprenorphine or methadone reduces mortality risk, and shows that for both opioid agonist treatments, there was a strong protective effect. Methadone was 0.47, the risk ratio, and buprenorphine 0.34, but consistent between the two of them. Next slide, please. Here in this slide, I summarize the evidence for different causes of death. So again, does opioid agonist treatment reduce different causes of death? So, and there's a substantial impact on injury, which is the first row, overdose, drug-related poisonings, the second row, and interestingly, suicide as well, which is the third row, all under 50%, a 50% reduction among people who are on opioid agonist treatment. And there's weak evidence also that being on OAT reduces other causes of death, reduces liver disease, cancer, and cerebrovascular disease, but not to the same level. We found in these cohort studies no evidence for a reduction in HIV-related causes of death or bacterial skin and soft tissue infection causes of death, at least in these studies. Next slide, please. So here we wanted to look at different periods on or in opioid agonist treatment and off opioid agonist treatment by the different modalities. So in this Fourier plot, we've aggregated to, in the first 2 rows, it's for methadone, and the second 2 rows, it's for buprenorphine. And so in the first row, it's looking at the mortality risk in the first 4 weeks on treatment on methadone. In the third panel is looking at the first 4 weeks on buprenorphine compared to the rest of the time on buprenorphine. In the second panel, it's looking at the first 4 weeks out of treatment for methadone compared to the stable period on methadone. And the last panel is looking at the first 4 weeks out of buprenorphine compared to the rest of time on buprenorphine. And so what we can see is overall that there's a 6 times higher risk of mortality in that first month leaving opioid agonist treatment for both methadone and buprenorphine. Overall, there's about 2-fold risk in the first 4 weeks of treatment on opioid agonist treatment, but this is all on methadone. There is no excess mortality risk for patients on buprenorphine in the first 4 weeks of treatment. It's just, but there is both leaving opioid agonist treatment, either methadone or buprenorphine, there is this very high elevated risk of death in that first 4 weeks. Next slide, please. So this slide summarizes the evidence for opioid agonist treatment delivered in prison. And interestingly, we found only one study in Australia looking at mortality risk in prison for people who were given opioid agonist treatment versus those who with an opioid use disorder and in prison who weren't given opioid agonist treatment as maintenance while they were in prison. And here they showed that there was an almost 75% reduction, or a risk ratio of opioid agonist treatment. It was 0.24, a 75% reduction in mortality if people were given opioid agonist treatment in prison than if they weren't. And what they showed was that the mortality risk in people not on OAT, and these are people with an opioid use disorder in prison, was about 2% per 100 person years versus 0.6 per 100 person years if they were on opioid agonist treatment. But this one study clearly needs replication. We found 2 studies that looked at the impact of leaving prison for people who are on an opioid use disorder, leaving prison for their mortality risk in the first 4 weeks post-release. And the studies were one in the UK and one in Australia. And here we see that if prisoners with an opioid use disorder were released on opioid agonist treatment, their mortality risk, their overdose death risk was about 3.5 per 100 person years, compared to if they were detoxified or they weren't given any treatment in prison and they were released. That mortality risk from overdose in the first 4 weeks was nearly 2%, 21 per 100 person years. No, it's more than that, 21%, 21% in that first four weeks. And the risk ratio impact, basically leaving on opioid agonist treatment reduces that mortality risk by 80%. And in fact, what you can see is that leaving prison on opioid agonist treatment removes the elevated risk, so that the level of risk for people is the same as other people in the community. Next slide, please. I hope I'm not going too quickly. Anyway, you're supposed to tell me if I'm going too quickly. I want to. The next 2 slides are summarizing some model evidence. So we wanted to look at the mortality risk in 3 sites, and we selected Kentucky in rural United States, Kiev in Ukraine, and Tehran in Iran. And this slide shows the mortality risk that we observed in some cohort studies in those sites in people who inject drugs. And it compares it to the mortality risk in the general population. And you see the same things that we saw in one of the earlier slides, is that there is a heterogeneity in mortality risk. So people who inject drugs in some countries have got a much higher mortality risk than others. For example, in Kiev, in Tehran, the mortality risk was much higher than in rural US. And this, but also that in all 3 sites, the mortality risk in people who inject drugs is much higher than the general population. Also, there are differences in the causes of death. So in these 2 populations, which I won't talk about very much, that the HIV-related causes of death was substantial in both Kiev and Tehran, but not so much in Kentucky in this study. And that the ratio of suicide and drug-related and overdose also varied. If we go to the next slide, please. Okay, so this summarizes a series of different models looking at those 3 sites. And the first row is what would be the mortality risk in those 3 sites if there was no opioid agonist treatment, if opioid agonist treatment in those 3 sites had been taken away. So in other words, how many deaths were being averted in those 3 sites, compared to the second column, the status quo, which was the number of deaths being averted by the current programs. And what you'll see is that there is very little difference between the mortality risk without opioid agonist treatment versus with it, the current levels of treatment in those 3 sites. And that was because there is very little coverage. There is very little opioid agonist treatment in those 3 populations. So they're not averting many deaths. In fact, Tehran is probably averting more deaths than either Kiev or Kentucky in this study. Then we go to the scenario 2, which is the third column, which says let's increase opioid agonist treatment up to 40% coverage in the population of people who inject drugs, people who've got opioid use disorders. In scenario 3, we then improve retention in opioid agonist treatment to about 2 years on average. And finally, in scenario 4, I won't talk about the last one. Scenario 4, we also introduce opioid agonist treatment in prison, so that people with opioid use disorders who go to prison are given opioid agonist treatment and then they leave on opioid agonist treatment. And what you can see is you increase coverage, improve retention, introduce opioid agonist treatment in prison, you can have a substantial impact on mortality risk in all of those 3 sites. You can reduce overdose deaths by 1/3 to 50%. You can have an impact on self-harm and self-suicide of about 30%, and you can also have a substantial impact on other causes of death. Next slide, please. But that's if you like, model estimates or projections of what could happen given some good coverage and good treatment services. What we really need to start doing much more of now is looking at, well, how good is the delivery of opioid agonist treatment programs in different countries on drug-related deaths. In other words, how many deaths are being averted by that program? So the slide on the left, which was from some old data in the UK, shows what's the relationship between the average duration of treatment on opioid agonist treatment and the probability that OAT program reduces mortality risk in the population. So it's only when you start to get to average durations of treatment of above a year do you get to think that you've got an 80% probability that you are actually averting deaths in the population. And when we did that study, that was a few years ago, average treatment of OAT in the UK was below a year. So the distinct possibility that they weren't having an impact on OAT in the population. In the right-hand panel, this summarizes data that was just coming out in in addiction, a model where we looked at people on the opioid agonist treatment program in Sydney and New South Wales from 2001 to 2020. So we simulated the cohort. So there were nearly 50,000 people who'd ever had opioid agonist treatment from 2001 to 2018, and then we could model what impact that would have on mortality till 2020. So there were 50,000 people who had ever entered the program. On average, each year there were about 16,000 to 17,000 receiving opioid agonist treatment. The duration of treatment was on average about 1.7 years. And over the cohort period, people had on average 3 to 4 episodes of treatment. Equally, we followed them in and out of prison. So approximately 1 in 4 had a prison history, and on average 7% were in prison at any time during the year. So there were over 5,000 deaths that we modeled and 1,500 overdose deaths. And the mortality rates were about 1 per 100 person years for all cause and 0.6 for drug-related deaths. So when we fit the model to the cohort, to people coming in and out of treatment, in and out of the community, into prison, whether they go into treatment, leaving prison on treatment or not, we can then say, well, did that program, what evidence is there that it averted deaths? And this is what we show in the figure. So that we estimated or projected that actually the program averted 50% of overdose deaths and over 50% of overdose deaths and 27% of all-cause deaths. So in other words, in people who'd ever been into that program, the number of more deaths would have been over 50% higher for poisonings, for drug overdoses, and 27% higher for all-cause mortality. And the prison program itself of opioid agonist treatment in prison, that reduced overdose deaths by about 12% and also averted 5% of all-cause mortality. So evidence, at least for people entering the OAT program, that they were making a difference. The program was making a difference. It was averting deaths. Next slide, please. I've lost track of time, so I think this is my last slide anyway, so that's fine. So I wanted to, so from our review level evidence, we can show that opioid agonist treatment is strongly associated with a lower risk of mortality, as well as HIV, as well as hepatitis C transmission. And it's a lower risk of multiple causes of mortality. Suicide is lower, cancer was lower, alcohol-related, cardiovascular-related causes of death were lower, and overdose drug-related deaths were lower. But mortality also is elevated when people leave opioid agonist treatment programs. And for methadone, in the observational study, it's also slightly higher in the first month going on to treatment. We've got emerging evidence that opioid agonist treatment in prison is effective at reducing mortality risk in prison and in the critical period leaving prison. And that definitely needs to be strengthened and also needs to be promoted. We've got a new drug strategy in the UK, and there's been various people from the Ministry of Justice saying one of the things we might want to do would be to only provide detox in prison, which would be a disaster, and hopefully we will get to emphasize that that would cause more deaths than save. And retention is critical to achieving population benefits of opioid agonist treatment. We've shown in models how scaling up OAT, improving retention, providing it in prison can have substantial population impact. And in one study in Australia, we've actually evaluated that program and shown that it does avert deaths. We need to expand that model in Australia to all people of opioid use disorders, not just those who have come in to an opioid agonist treatment program, but also now start to use that same modeling and the same data, cohort data, in other countries, in France, other countries in Europe and the UK, so that we can then strengthen the evidence of how opioid agonist treatment can reduce mortality risk and contribute to reducing deaths of despair, as Jürgen talked about earlier. Thanks very much. I hope I didn't go on too long. That's it.
Thank you very much, Professor Hickman. It was a very impressive and big picture of the question. We have time for a couple of questions.
Oh.
Are there any questions in the room? I will begin with one. Do you have, can you hear me?
I can't hear.
Okay, thank you. Could you give a couple of words about the interest of this treatment in the crisis of opioid as painkiller? Hello?
Oh, yeah, sorry, I missed half of that question, sorry.
Yes, you know, in the US there is a crisis of opioid used as painkiller.
Yeah.
What is the effect of methadone, buprenorphine, etc., all this treatment on this epidemic?
Well, I think in our modeling in Kentucky, there's no, you know, we project that if you increased opioid agonist treatment programs and also retention, you would have an impact on drug-related deaths. I think there's been an evolution. I mean, Jürgen can answer this probably better than I can. There's been an evolution of the causes of the opioid use problem in the United States. He may as well have started from over-prescribing of painkillers, but actually has moved on to other opioids, and now obviously there's a crisis with fentanyls. So, you know, the real question at the moment is what kind of treatment programs are required to address fentanyls as well as the problems with other opioids.
Okay, thank you. Are there other questions? No. So,
fair enough.
Thank you, Professor Hickman, and have a nice afternoon.